This conference will now be recorded.
We apologize for all these issues that we're having today. We're going to talk about the agreed tools, what are they and how to use them. And next slide, please. No financial conflict of interest to declare today, and and I have some non-financial conflicts. I am the current leader of the agreed collaboration, and of course, I am supporting the tools, and I am the director of Cochrane Colombia. Next, please. So to start our definitions of what is a clinical practice guideline, but you know that guidelines are systematically developed statements to assist practitioner and patient decisions about the appropriate healthcare for a specific clinical circumstance. There are a couple of additional definitions out there, like the WHO, but I will use this, which is a good summary of what are guidelines, which are in the end recommendations or statements that are systematically developed. Guidelines are used in all the levels of the healthcare system. It could be used mostly by clinicians for taking decisions at the clinical level in those decisions that happen between the clinician and the patients, but also different stakeholders in the healthcare system are using guidelines for decision at the minimum, at the medium level, but also at the high level in the healthcare system. So they play an important role in informing all the decisions for health policy, and they have evolved from the clinical perspective to this methodology has been used also as well as to cover topics across all the healthcare continuum. That means that we also have guidelines for health promotion, for screening, for diagnosis, for preventive, for public health, and also health system guidelines. So many of the methodology that we applied, that we started applying for clinical practice guidelines for clinical purposes, are also applied to other kind of guidelines that goes to for different to respond different questions, as we will see during the presentation. Next, please. So when we talk about guidelines and what is the quality of guidelines, it is good to make a brief summary of what are the standards of a high quality guideline. So to be considered a high quality, a guideline should be transparent in the funding and support. It should be very clear who is funding the guideline, who or what organization are supporting the guideline development. It should be a multidisciplinary process, balance and representative composition of the group. That means that we are doing a guideline for a specific topic. All the potential stakeholders, clinicians, healthcare workers that are involved in the management of these of patients with this disease should be represented in the group, and that means all the disciplines that should be involved in this kind of management for each specific disease. Patients' values and preferences should be considered. If we do guidelines that are only focused on the evidence of effectiveness, and we are not asking patients what are the values that they have, what are the preferences, we are doing a guideline that is not of high quality. Conflict of interest should be handled, disclosed and handled, and that's a key element in guidelines, because very commonly guidelines are developed by experts, and experts very commonly have a potential conflict of interest that could be very, very problematic when they are doing recommendations. So the disclosure of these conflicts and the handling is a key element of a high quality guideline. The development of a pre-established scope and question of interest. Guidelines should be before starting, should be very clear about what are the scope and what are the questions that are going to be covered. And that means that's a kind of new recommendations that we are encouraging authors of guidelines about registering guidelines, as we usually do for systematic review and clinical trials. So pre-established scope, pre-established question is a key element for a high quality guideline as well. Systematic and transparent. The search of the evidence, the systematic review process, the eligibility criteria for selecting the evidence should be as well very established in advance. The methodology for assessment of the quality of evidence, of course, should be very transparent and very clear. And the process of how the group is moving from the evidence to developing the recommendations should be very clear and very explicit in the guideline process. Next, please. Another point of interest is that the methodology could be of high quality, but the process of how the guideline is presented is also as well very important. For this, that means the guidelines should have very clear recommendations, explicit and non-ambiguous. The guidelines also should include tools to enhance their implementability, and they should have considered cost and resources used. Cost is also a key element for making recommendations that are more implementable and feasible. Guidelines should have considered equity issues. We have had in the last decade a huge interest in improving all the issues related with equity. When we do recommendation, we don't want to create equity gaps in the healthcare of patients for specific diseases. And also guidelines should be reviewed before publication by peers, by peer reviewers, and the process of updating a guideline should be very explicit and very detailed. And that is, if we have had 1 year or so to develop a guideline, we have had a group of experts developing and assessing the evidence. All those experts are in the best position to say when a guideline should be updated according to how the evidence looks and how is the evidence that is ongoing and is going to be available, when it's going to be available soon. And they should provide a clear definition of when or when they think the guideline should be updated. Next, please. So the question is, do the users know how to identify good clinical practice guidelines? People who use guidelines, who read, who apply, who are using the recommendation of guidelines, and I mean clinicians and decision makers in general, are very trained in clinical practice guideline development in all these steps and all these criteria that I just mentioned. Are they experts in assessing systematic reviews? Are they experts in interpreting this evidence, in interpreting meta-analysis, in interpreting the cost-effectiveness evidence, in the concept of values and preference evidence, and also implementability evidence, and how people assess the quality of evidence in the guidelines and how to develop recommendations. So most of the time, in almost all the cases, most of the users are not trained in this. That's why, next please, we as users need, next please, yes. That's why we think that users need help in assessing clinical practice guidelines. There are many methodological processes in a good guideline, in a high quality guideline, that most of the users are not trained in. Next, please. Next, to make it easier and faster. Thank you. So most of the users have the inability to differentiate what is a good guideline and a bad guideline. And the bad guideline, those very low quality, methodologically speaking, low quality guidelines may lead users to recommend treatments that are ineffective or are even harmful, or treatments that have no value for money and therefore they will lead to an increase in healthcare expenditure, or treatments that are not implementable even though they are effective and even cost effective. Some interventions are not going to be affordable or are not going to be implementable, which will create gaps in the healthcare system and inequalities in the end. Next, please. And bad guidelines could lead users to use these treatments that are not implementable, are expensive, or are not available. That's why AGREE exists. AGREE means the appraisal of guidelines for research and evaluation. This is a collaboration of researchers aimed to create tools and resources to support guideline enterprise. For many of you, AGREE is not an unfamiliar word. It's not an unfamiliar term. But for some of you, maybe it's the first time you're hearing it. So next, please. What does AGREE do? So the idea, the idea is the AGREE has been developing tools to optimize the quality of guidelines, to minimize the bias and ensure the usability. If we have a high quality guideline, the methodological process is going to be followed and the recommendations are going to be of high quality. And in the end, these recommendations that are based on the best evidence, considering all the other aspects that I just mentioned, we're going to obtain recommendations that are of high quality. And recommendations that are of high quality are going to be more implementable and going to be more used. That are going to be guidelines that are going to be more successful. So the idea of the AGREE is to create tools that are used to evaluate the quality of guidelines, and they also serve as a blueprint for people who are developing and reporting guidelines. So as you can see, you have here in bold 3 terms, which are evaluation, development, and reporting. People who are going to use the guidelines could apply the tool to see if the tool is a guideline is of high quality, but also developers, people who are developing the guideline, who could use it to follow as a guidance to develop their guideline. And also the final reporting or the final writing of the guideline. That's why AGREE also serves purposes on reporting of the guideline. Next, please. That is the aim of the AGREE. And how does this start? Next, please. The history of guideline goes from 1999, when Françoise Clouseau in the UK created, as part of her PhD thesis, the first tool for assessing, or the first validated tool to assess the quality of guideline. And that it was called at that time the Clouseau's instrument, which was published in 1999. And that was kind of the basis for the developing of AGREE. After this work, a collaboration of experts between the Europe, UK, and Canada started this collaboration, which was called AGREE, and in 2003, supporting on or based on the Clouseau's instrument, improved the tool and make a validation process to create the new tool, which was called the AGREE, was published in 2003. In 2009 and 10 was published the second version of the AGREE tool, which was improved in the number of items and also in the way the items are scored. So in 2010 was published and led by Melissa Florez in McMaster University and funded by the Canadian Institute for Health Research, the AGREE 2 tool, which is the one that is currently available right now. Next, please. So this is a brief history of how AGREE was created. Some important people to mention here. Of course, I'm not going to read all these names. These are all the people that have participated from the beginning since 1999 so far, at some point of creating one or more of the tools that I'm going to mention today. So I'm it happened that I'm just the current leader of this collaboration of international experts that have collaborated at some point in creating this tool. So all the acknowledgement to those people, especially to Melissa Florez, who was the leader of the AGREE tool. Next, please. As you can see, it's an international collaboration of people. What does AGREE do? We create tools that follow all the same methodologies as you can see summarized in this figure. And this tool is, we started with an item generation. The item generations is create a list of items that are going to be covered in a tool. And the creating of that item has a process to select the best items that are going to be covered, usually by a systematic review and a consensus of experts to decide what are the items that are going to be covered. The item generation goes through a huge process of item reduction and then scaling and clustering in order to get clusters of domains that cover the same topic and encompasses many items inside. And all this process of clusters, and then we create a draft tool, and that tool goes through a long process of reliability and validity process. And these studies of reliability and validity are key for us to keep tools that are based on are evidence-based. That means tools to assess the evidence, the quality of the evidence, but at the same point, they are created through an evidence-based process. And this reliability and validity process gets us in a cycle in which we can try to refine the tool, to find what is the best tool for the specific process. And we have the final tools, as I am going to mention. And during all this process, we have a usability process as well, in which we ask users about how they feel with the tool and what are the things to improve. So all this process is followed in all the tools that I'm going to mention. Next, please. So we have a portfolio of tools. I'm going to go very rapidly through most of them. I'm going to spend a little bit more time AGREE 2 and AGREE Rex, which are the most important tools, and I will mention why. Next, please. And the AGREE 2 is the one which we are going to start. Next, please. The AGREE 2. Next, please. And I mentioned a little bit because all this collaboration started with AGREE 2. Next and next, please. Two times. Yes, please. And what is the role of AGREE? AGREE is for development, as I told you before. That means for groups who are developing guidelines, People who are developing a guideline could follow all what AGRI recommends for reporting. People who just finish their guideline and they are trying to finalize the final guideline document or paper, and it is a good guidance and like a way to help people to report that final document. Writing a final guideline report is a huge task. It has a lot of information, and the organization of this is key, not only for users to understand, but also for decision makers that need to take decision with them, but also for patients who are going to use guidelines at some point, or for people who from other organizations who are going to adapt those guidelines in the context. For appraisal, and that is kind of the most important task, or sorry, the most important use of AGRI tool. Most of the people know the tool because they use it to assess the quality. So for potential users, people who need to take a decision about what guideline to use, what guideline to implement in their context, or what guideline to adapt to their context, you can use AGRI, make a score, and define what are the best guidelines to use. Next, please. So, and all of the above. It's not about one or two or three. It could be about all these specific roles that I just mentioned. Next, please. Who can use AGRI? So anyone, any healthcare provider, physician, nurses, dietitians, psychologists, or people who are developing guidelines, or people who are interested in adapting guidelines, or policymakers, people who need to take decisions about drugs, about healthcare services reforms, changes, decisions, educators, people who are interested in teaching at a graduate level or an undergrad level about critical appraisal of guidelines. And very important, there is no specific background for it. So there is not need to have a master's degree in clinical epidemiology to apply AGRI. Of course, most of the concepts that are behind AGRI are related with clinical epidemiology, with evidence-based medicine. So it is expected that the people who are going to use it could have a basic knowledge on evidence-based medicine concepts and guideline development. It will be easier for them to understand the tool. However, the tool has been created in a way to be as easy to use as possible for people who doesn't have a very advanced acknowledgement on clinical epidemiology. Of course, training is key. For those people who are not very familiar with the tool, any kind of training from people who have some kind of expertise or are more trained in the tool would be useful to apply. Regardless of this, the tool and the manual to apply the tool, not only the AGRI tool, but also the other tools that I'm going to mention today, have very detailed explanation on how to score, on where to read, where to look for specific concepts in a specific guideline, and how to make decisions about how to score. So the manual is very user-friendly, but of course, some kind of training and basic knowledge would be very advisable for applying the tool. But in general, anyone who is interested in guidelines, either for development, or for adapting, or for implementing, or for using, could apply AGRI. Next, please. So the AGRI tool has 23 items. Many of you are very familiar with the tool. The 23 items are clustered in 6 domains. The first domain is scope and purpose. And that domain is concerned about how clear the guideline is about their objectives, the scope, what are the questions that were covered by the guideline in advance, and what is the population of interest? What are the patients or the population of the public who are the focus of the guideline? That's the first domain. The second domain is stakeholder involvement. And stakeholder involvement is about who wrote the guideline. Who are the people who were invited to be part of that discussion in the table and in providing recommendation? Were all the groups interested in this specific disease invited to be part of the panel of the guideline? If it was an obesity guideline, were all the specialists and healthcare workers involved in the obesity management or diagnosis or rehabilitation or whatever invited to be part? Do we have dietitian? Do we have nurses specialists in this management? Do we have psychologists? If the guideline scope covers something about mental health, that means all the professionals are involved in the management should be represented in that table. Also, we need to ask patients, what are the target population? The people with the disease were invited to be part. Did we take into consideration the values and preferences of the patients? And the guidelines should be very clear about the target users. And the third domain is rigor of development. The rigor of development covers many items that I'm not going to read because of time, but it's about all the process of systematic reviews that are behind each one of the questions. There was a search strategy or not. There was very clear criteria to select the evidence. The strengths and limitations of the evidence were assessed. What tool was used. The health benefits and the harms were considered simultaneously. There was an explicit link between the evidence and the recommendation. The guidelines has been reviewed by experts before it's published, and if there is a clear update process of the guideline. That is the rigor of development, and for many people in the guidelines world, it could be the most important domain, which is the third domain of the GRI tool. The clarity of presentation is the fourth domain. It has 3 points, as you can see there. And that means that regardless of the methodological process, the guidelines should be very clear and explicit, and they shouldn't be ambiguous. They should be easy to find, and they should have very clear course of action of what to do. Applicability domain is the fifth domain, and the fifth domain is about how applicable the recommendations are going to be, and that means covering issues like implementation, how are their monitoring and auditing criteria considering, were costs considered, and if the guidelines provide a clear barriers and facilitators analysis for the recommendation. And the final domain is the editorial independence, which has only 2 items. It's about who funded the guideline and if the conflict of interest were handled. This is a brief summary of what are the items. As I told you, that the manual provides a specific detail of how to score each one, and all the explanations are there provided. Next, please. So each one of these items, each one of the 23 items has a score that goes from 1 to 7. This is a Likert scale, and this Likert scale goes from strongly disagree, that means that the guideline didn't cover that item or cover it in a very badly way, and strongly agree, which is the opposite, the other extreme of the score, which is 7, which means strongly agree, which means that the guideline covered really well that item, each one of these 22. And with this score, we provide a final score per item, and we create a final domain score. If we can go back a mirror, please, sorry. That means that even though we score for each one of the items, for each one of the domain, we get a final score. For instance, for the scope and purpose, which is the first domain, we have 3 items. We get a 1 to 7 score for each one of the 3 items. But at the end, we put everything together and we get a final score that is in a percentage that goes from 0 to 100%. So for each one of the 6 domains, we're going to have a percentage that goes from 0 to 100%. 100% meaning the best score possible. That means that the guideline covered really very well this specific domain. So that means we're going to have at the end 6 proportion or 6%, once per each domain, not per item. Next, please, and next, please, Amir. And this is how the domains are scored. There is this formula to make all the calculation and to get the final scoring proportion, and that is very explicitly detailed in the manual. And we obtain a final percentage for each one of the domain. Next, please. From 0 to 100%, as I told you. So this is an example of how we got three specific clinical practice guidelines. These guidelines are for a specific disease. We get proportion, that means percentage, for each one of the 6 domains for each guideline, and we could compare. In this case, we could get that the rigor of development, as I told you, was one of the most attractive domains. The clinical practice guideline number 3 has 90% of rigor of development, which means that the methodology to do the guideline systematic review process was of the highest quality, while the clinical practice guideline had 39.5%. It's in red, and the rigor of development, third domain, had 90.3 in the third guideline. So we could compare. And this is just an example with rigor of development, but we could also compare it across the rest of the domain to see which guideline we prefer or not. As I told you, we usually give more weight to the development, to the rigor of development, because it's all the systematic review process. This is a way we could present the results. Next, please. So how do we interpret the results? We use the result to identify what are the strengths, what are the limitations of the guideline. We compare methodological quality between guidelines. We could select what are the highest quality guidelines for adaptation, for endorsement, or for implementation. There are no magic thresholds, and this is kind of the most common question that we receive, is that you provide a score, and we need to, people ask us for a specific threshold about what could be the good guideline, what is a bad guideline. There is not magic threshold to say above this percentage, these are good quality, good guidelines, and below this threshold, there are bad guidelines. That's a threshold that is up to the users to take a decision depending on the number of guidelines, of the context, and the quality of guideline that we have. It's not the same context in which you have all the guidelines above 80% in the rigor of development, rather than having some guidelines that have 40, 30, 50, and there are not many high quality guidelines. So it's up to people who want to use the guideline to take the decision what is the score that they're going to use. So there are not magic thresholds. At least we, as agree, we don't recommend a specific threshold. There are some thresholds that people are used in the literature from 50, 60, or 70% or above to define what is a good quality guideline for a specific domain. Next, please. Next, I'm going to pass this really fast. Next. Just to say that there are many examples of how to do the assessment, how to define. You could decide that domain 3 is the most important one, and you could use 70% to define what is the high quality guideline. Or you could do by stages, in which you could filter, and you have 50 guidelines to assess. You could apply agree to the, you don't have time to apply agree to all the 50 guidelines. You could use just domain 3, apply only domain 3 to all the 50 guidelines, and choose what is the guideline that have the highest quality. And when you have the best, let's say the best 5 guidelines out of 50, you could apply the full tool, the rest of the domains. That's a way to apply. That's one example to when you don't have too much time, because the tool requires some time. And there are additional examples, and I will provide some reference citations where you could get more information about this. Next, please. As I told you before, what domains? Usually we prioritize domain 3, but in some cases we need to prioritize domain 6, which is about editorial independence. And that happens when you have a lot of guidelines in which you are very concerned about conflict of interest management. And then you need to say, okay, I am going to make a cutoff about 60% in only those guidelines that have more than 60% in the editorial independence domain, because there are a lot of conflict of interest in these guidelines. That could be a way to do it. Applicability domain is one of those domains that for some of us is a little bit flexible, because there are some cases in which the organization that develops the guidelines is not the organization that is in charge of doing implementation of the guideline. And in that case, some guidelines are not providing very specific, they don't have the mandate to provide specifics about applicability, to provide quality indicators for barriers and facilitators, and that could be very context dependent. So the fifth domain is one domain that in some cases we could consider a little bit flexible, and we don't recommend to use it as a specific threshold as the only way to define a high quality guideline. But it depends on each context. It's up to the user to decide. Next, please. So that is the manual. As I told you, each item has all the information. The manual has been translated to 20 languages. And if there is any language there in the website that I'm going to show you that is not available, and many of you would be interested in working in a translation for that manual, contact us, and I will provide contact information at the end of the conferences, and we could work on a translation for any specific language. 21, and we need to update this, so we have a lot of languages available for this instrument. And all the information is there in the manual that is freely available. Next, please. This is a great website for those of you who haven't had access to. It's just agreetrust.org, and you can have all this information that I have provided today. You could have access to the tools, to the manual, freely available, as I told you, and some news about Agree and new tools that we are created. Next, please, and you could have access to the Agree Plus tool. The Agree Plus tool is what you see here. It's inside the Agree Trust website, and you could create free username and password. You create your account, and in your account you could do online an Agree assessment, as you can see in the right of your screen. That's how you can see all the domains and all the items, and it provides an easy way to do an assessment, and you don't have to use a PDF or print the paper, and to provide the final score, and it will get you the final scores at the end, and it has all the manual description information there in the website, so you don't need to do it in a PDF or in a printed way. So, and you will get at the end a PDF, like a summary of your assessment, and you could do assessment for a course in the university when many people are assessing the same guideline, or you need to do an assessment among 3 or 4 people that are in different parts of the world, and that's a way that you could do it through online. Next, please. So I invite you to provide that, to go to Agree Plus. So this is the most important tool of and this is kind of most of the people in the guidelines world use, but there are a couple of additional tools I wanted to briefly mention each one of them. Next, please. And AgreeRex is the most important one that we just launched last year. I'm going to provide some insights on it. Next, please. The AgreeRex tool started because there was the group. Next, please, but just to see all the domains. Yeah, next and next. I think you could stop there. So we were concerned about the implementability, because we knew that the guidelines could be of high quality, and at the end they could not be used. We have high quality guidelines that are not used by users. So researchers have been concerned about the implementability concept and the credibility. How to do guidelines that are more implementable or more credible. And then a realist review by Monica Kastner et al. Published in 2015 in Implementation Science, make a huge summary of all the concepts that are behind the implementability. What are the concepts that explain implementability of guidelines? And after that, a conceptual framework was created to explain the implementability of guidelines, and that was published in the paper by Browers in 2015, and in Journal of Clinical Epidemiology. So after those, there were a list of many domains, many items, and many domains that could explain implementability of guidelines. From that list of domains, we asked experts around the world about what of these concepts and domains haven't been covered by tools previously, like Agree, or approaches like GRADE, or any other tools or approaches. And we found that the key domain, deliberation and contextualization, which in summary is all the things that we discuss when we have the evidence in front, and what are all the values that are brought to the table before a group provides a recommendation, that domain wasn't covered before by any tool or approach. So that's why the group decided to develop a tool to evaluate this domain, because the experts told us that there was no tool for that and there was a need for that. We did a phase validity study, and we did a usability and validity study that I'm going to show you in the next slide. And we finally, sorry, there is a sentence here in Spanish. We finally developed a tool that is called the AgreeRex tool. So next, please. That was published in 2020. So this is a tool that was created after a systematic review of the implementability concept, when we asked experts about what tool was needed, and they told us, yes, we need this tool that covered this specific credibility and implementation and implementability concept, and we did this validity process. Next, please. This is the grid regs, which mean credibility and implementability of recommendation. Next, please. And we published these 2 papers last year. In JAMA Network Open, we published the validity and reliability study, where we show all the process that we follow to develop the tool, where we found that the tool was valid, reliable, and people like it, and people thought there was a need. We asked more than 300 people around the world, among guideline developers, guideline implementers, and guideline users, about the tool, what they thought. If it was a tool that was not neat, it was a tool different from Agree 2, there was something that is going to be useful for developing and for implementing the recommendation. And in the second publication, which is in implementation science, we published the final scores of 161 guidelines that we use to do the validity and reliability study of the Agree regs, which is published in implementation science, as I told you. Next, please. So we created this tool very similar to Agree 2. It's just that I only have 9 items, and it's about, they are clustered in 3 domains: clinical applicability, values, and implementability. And these domains are about the evidence, how relevant is the evidence. It's not about the quality of the evidence, it's about how relevant is the evidence and how relevant is for patients as well. And when we talk about the second domain, which is values, we will also talk about, did the guideline consider the guideline developers' values, the target users' values, the patient's values, and the policy values as well, because this is important for guideline implementability. And for in case of implementability, we discuss about the purpose of the guideline, if it's clear enough, and the concept of local applicability and how costs were considered. It goes from 1 to 7, and the scoring is very similar to Agree 2 tool. So it's not 9 items, and we get 3 domains, 3 scores, 1 per domain. Next, please. And the Agree regs tool, which is a little bit different from the Agree 2, could be applied to the whole guideline, but it could also be applied to a specific recommendation. Now, for Agree regs, the unit of analysis is not only the guideline, but each recommendation, because each recommendation could have a different discussion and different values and preference consideration than other recommendations within the same guideline. Next, please. It has been translated to 2 languages, Agree regs manual, and we are working on additional languages right now. It focuses on the recommendation. It can be applied to the whole guideline, as I told you, but also to a specific recommendation. It brings new concepts that were found to be very crucial for recommendation, but they weren't covered by Agree or many other approaches before. It complements the Agree 2, but it can also be used separately to assess a specific recommendation, 1 or 2, or a bunch of recommendations. Next, please. Next, please. Yes, the same as Agree 2. It could be used for assessment, endorsement, or reporting, the same. And this figure here kind of summarizes it. It was published last year in a paper we did as a commentary in the Journal of Clinical Epidemiology, in which we provide some insight of how to use the tool, what is Agree 2, what are all these discussions I have showed you today, and how to use Agree 2 and Agree regs. This figure, I'm not going to go in depth because of time, is sometimes you need to apply Agree or Agree regs to 20, 30, or 50 guidelines, and there are several approaches that you could use. You could use Agree regs, which is a shortcut tool to select the best 5, and when you have the best 5, then you apply the Agree 2, which is a little bit longer tool. And there are different approaches here, or you could use one domain to all the guidelines, as I explained you before, and then when you filter the best guidelines, you could apply the full tool to the 5th guideline that you just chose. So it's just different approaches that are there for you available when you don't have too much time, you don't have too much resources, and you need to take a decision with a bunch of guidelines as soon as possible. Some approaches to use Agree regs and Agree 2. Next, please. Next. And finally, I'm going to describe you 2 final tools, which are the AgreeHS and CheckUp. Next, please. AgreeHS is a tool that was published 3 years ago, and it's focused, instead of being focused on guidelines, they are focused on health systems guidance document. And what is a health system guidance document? It's the same as a guideline. It's a systematically developed recommendations for statements. It's developed by a third party, by organizations, governments, or any other neutral parties. But something that differentiates from a guideline is that the questions that are in a health system guidance document are health systems challenges, not clinical questions. It's not about what is the best treatment, but it's about what is the best decision for a health system. Like, for instance, what is the best way, or what are the best interventions to keep healthcare workers in rural areas? And there are some interventions, there is some evidence that have been gathered, and we could provide recommendations that are going to be used by decision makers. Next, please. The health system, the AgriHS, next, please, is a tool. Next, please. It's published, the validity and usability process is published in Health Research Policy and System. Next, please. And it's a tool that is a little bit simpler: 5 items, topic, method, participant, recommendation, and implementability. It has a manual, the same as all the AGRI tool, and it has all the explanation of the AGRI tool to make the score from 1 to 7, and you can provide a final score. Next, please. It's a tool when you are in front of a health system guidance document, which shares some methodologies with clinical practice guidelines, but some things are very different. Next, please. And finally, checkup. Sorry, I was forgetting the AgriGRS. Next, please. The AgriGRS is a very simpler. It's a simpler tool. It's a short version of the AGRI tool, and we call it at the beginning the global rating scale. We also call it AgriGRS. Some people call it the AGRI short version. This is a very simple 4-item scale, tool that assess only 4 items, which are the quality of guideline development methods, the quality of guideline presentation, the quality of reporting, and the quality of the recommendation, and an overall final score. It went through all the validity and reliability process. Of course, it's not as comprehensive as the AGRI tool, and that means that it could have some differences in the validity and reliability, but it's a good alternative way to assess when you have resources limited, when you have to assess 120 guidelines. That's a way to filter and then apply AGRI tool to the best one. So it's another tool that is there, very short version, easier to apply. Next, please. And finally, we have checkup. Next, please. This was a checklist that we created in a collaboration between our team in McMaster and the team of Pablo Alonso Coelho in Barcelona, in Spain. And we created this checkup, which is a reporting checklist to evaluate what are the items that should be covered in a guideline that has been adopted. So we published this in PLOS Medicine in 2016, and in 2017 we published the first assessment of updated guidelines with the checklist. Next, please. It's just a checklist. It's not a tool to assess the quality because it didn't follow all the process for creating a tool, but it's a good way to facilitate the process for people who are developing, updating a guideline. It has 16 items, and these items are just checked, like cover or not cover in a specific guideline. As you will see, if you go in depth into the checklist, there are many specific issues that are only applicable to guidelines that have been updated. So it's a good way to start an assessing of the guidelines that have been updated. Next, please. Next, please. Oh, checklist. Next, that means that this is not a tool itself, is that each one of our tool has a checklist. We converted the tool into a checklist to yes or no, just to facilitate for developers who are writing the final document, just to see if they reported all the things that they have to report. Very similar as we do with Prisma in systematic review or Consort in clinical trials. So all these checklists are available in the website. Next, please. In summary, we have AgriTool tool, which is the most famous tool to do a complete evaluation of all the clinical practice guideline quality. It's the best tool, it's valid, it's reliable, and it has been demonstrated. It has been used for decades, and it's the most used tool. The AgriGRS is an alternative to the AgriTool in the context of scarcity of resources and time. It's a rapid tool, but it's not as reliable as AgriTool. AgriRex is the new one, is the newest one, and it's an evaluation of one recommendation or a bunch of recommendations. It can complement AGRI, or you could apply to specific recommendations. The AgriHS is for health system guidance documents. It's short, very useful, as we demonstrated in our usability paper. And the checkup is a checklist to evaluate the reporting of the guideline. It's not a tool, it's a checklist. It's focused on the reporting. Next, please. And this is the paper that I mentioned before that was published last year in Journal of Clinical Epidemiology, in which we provide more information of the tool, how you can access, how were they developed, and many of the information, many of the slides or the content that I provided today are provided in this paper. If you want to go and have more information about the thresholds and about the figures that I show you are are available in the paper. I can also share with Cochrane South Africa, and you could share with the people who attended today as well. This is our website again, agreetrust.org, and the social media, the Twitter account, Agree Scientific, for you to follow us and to be updated about the new advancements in the tools. Next, please. Thank you very much for all your time. Apologies for all the technical issues we had today. These are, again, our channel of communications, and this is my final email in case you wanted to have more information or you want more evidence about the tools. Feel free to contact me, and or again, the website, our Agree email, and our social media account. Apologies for all the time. I think we are on time, but I am able to respond additional questions if you think you could have any. Amir, thank you very much.
Thank you very much, Ivan. So at this point, I guess we can open up the chat, or if anyone would like to ask any questions, you can unmute yourself, introduce yourself. We'd love to hear some questions coming from you. So I see there's a question, is there an Android app for Agree too?
Yes, I saw it. No, we are working on, we are going to, you will see that the website is a little bit outdated right now so far, but we are working this year, maybe next year, we're going to update the website, provide more information. And one of the aims is to have an application for mobiles in which people could do the assessment and the quality assessment and navigate through the website in a mobile. Right now, there is no way to having an app, but that's something that we have in plan for next year.
And I guess the follow-up question would be, so are you working on Android first, or will it be Apple first, or both in parallel? There probably are some Apple users out here.
Oh, no, the idea, we haven't gone into the details. Maybe we start with Android because there are more people. It's my feeling that there are more people with Android than iPhone. I am an iPhone user, so maybe we will start with iPhone first. We don't know, but the idea is to have both. The idea is to have both.
Okay, that's great. Thanks, Guy. I'm guessing a question that I'll ask everyone is, you know, if there have been any participants that have used any of the Agree tools, be it one or two, and what your experiences have been using these. I think it would be quite interesting to know who's used them thus far. So I mean, I'm not sure if you also followed the chat over there, but are there publications on experience acceptability of users after the publication of tools?
Okay, so that's a good question. When the tools were created, all the tools, when they were applied and they were created, we did validity and reliability, and we did usability. And that usability involved asking users how they felt with the tool. So at least there is a usability published about all the tools, about how people feel with that, and how how happy were they with the tool? And the response was really, really good. Went from a Likert scale, and we had that most of the people were really happy with the tool and were easy. And usually when we were doing the process, we get from them feedback. And that feedback is usually incorporated into the manual and into the tool in order to improve the usability. So that's the first thing. After that, there has been many papers using Agree. The Agree 2 papers have been cited more than 3,000 times. People are using it, and we have had papers every week about assessing the quality of guidelines with Agree for different topics. And in general, what we feel, we haven't had like a survey all around the world to see how people feel. What we have felt is that there are some things that need to be updated in Agree, and some people are expressing some concerns about some topics because the methodology of guideline has been improved in the last decade very fast. There are more new methods, and maybe some things need to be updated. That's something that we're discussing as well. And we have had that in general, most of the people are very happy with the tool, except by one, the tool requires a little bit of time. We're talking about 23 items, and most of the people take 1 to 2 hours or maybe more for assessing. So most of the people, the most common concern would be the time. Is time-consuming tool, at least for Agree 2. The rest of the tools are a little bit shorter. The other thing is that people would like to have a threshold, like a cutoff point to say, above this threshold is a good guideline, and below this threshold is a bad guideline. We cannot provide that. We don't have evidence to provide that 60 is better than 65 or than 55. That's kind of the, but in general, there are not usability after that for Agree, but most of the people are very happy with it. That's for Agree 2. For Agree Rex, which is a little bit, it's really a younger tool. We have had so far 6 or 7 papers using Agree Rex, and we haven't had usability after that. But some people have manifested that they are very interested in applying the tool. There is another question, Amir, if you allow me, I could take it, about the which tool can be used when adapting a guideline. That's a good question. We have some concerns from people who are adapting guidelines, who are trying to decide if an adapted guideline could be used. So there is not a specific tool created for guidelines that have been adapted. And adaptation is a complex process that there are different methodological approach. Okay, so we have adapt, we have development, we have wrap adapt, and there are a couple, 3 or 4 more methodological process for adaptation. So there is no tool so far valid and reliable that was developed only with adapted guideline. However, if you know about guideline, you could apply Agree 2. And when you apply the third domain, which is about the rigor of development, you could go to the original guideline that was adapted and to see how well they did the clinical, the methodological process. So you could use Agree 2 still, even though it has some limitation for adaptation. Some people are saying here that they have used Agree 2 tool assisting a colleague who is conducting a review guideline. How is different from the MOOS guideline? Are you talking about the MOOS guidelines that are used for systematic reviews? I don't know who is doing this question, Francina.
Because the MOOS guidelines are Francina. Yeah.
Yeah, the MOOS guidelines are to assess quality of systematic reviews and meta-analysis. It was a tool that was used before Prisma was a reporting tool, or Amstar was developed and was expanded all across the world. But MOOS are only focused on the specific systematic review. And as you know, guidelines are more complex process that requires having some questions, let's say 10 questions. And if we have 10 questions, we are going to have 10 systematic reviews. So a guideline is a huge process that have many systematic reviews in the process. So the MOOS is only applicable to systematic reviews, like Cochrane reviews, for instance, or non-Cochrane reviews. The Agree is the only valid and reliable tool for the whole guideline process, not for systematic review. I don't know, Francina, if that answers your question. Perfect.
Luciana says thank you. Okay, I'm going to give a few more seconds if there's any last burning questions. Alternatively, if no questions come to mind and you do have any, then you can always forward them along to us or to Dr. Florez, and we'll gladly see that those questions be answered. It doesn't look like there's any more typing or any more activity. I'm just monitoring if anyone's unmuted themselves. It doesn't look like anyone's unmuted.
Yeah, go ahead.
Okay, getting the thanks. So I think with that being said, thank you very much, Dr. Florez, for such an informative presentation and for discussing or addressing the questions at the very end. This is very informative. And thank you to all the participants for attending today's webinar. We always are grateful to have your inputs and your questions. Always very useful, and it helps others as well. Just a last note, so you would have seen that I've added the webinar evaluation link at the very end, and I'm going to add it again. And if you can kindly please complete the evaluation, as it does help us as we move along, and for future webinars that we do host, just to improve and make things go a bit smoother as we progress. Also, please note and please be on the lookout for the next webinar advert that will be coming out soon in the days to come, as we're just finalizing presenters and yeah, some logistics. So with that being said, thank you very much, Ivan.
Thank you very much, Amir. Thank you very much to all the participants for your patience today. Apologies